Here we go. So we're super excited to be here with all of you. We want to thank PBMI for having us, give us the opportunity to speak with you guys. We're really looking forward to a great couple of days with all of you, being able to share ideas and learn from each other. So as mentioned, I'm Scott Rosignol. I'm the Senior Director of Drug Value Strategy at Abarca Health. I've been in the industry for almost 12 years now, mainly focusing on helping to set strategies for health plans and plan sponsors to drive growth and revenue optimization. Despite being on the PBM side of things now, I actually spent the majority of my career on the health plan side of things. So I've sat in the same seat that a lot of you guys have sat in. I've been on the other side where I've wrestled with those challenges of navigating PBM partnerships, trying to manage rising costs of both pharmacy and medical, trying to create solutions that meet evolving client needs, and balancing member access and financial sustainability. And given the market pressures that we're all facing, I think we can all agree, and even the government agrees, that the legacy PBM model isn't built for the future we're heading into. So just to set the stage of what we're going to talk about today, the primary goal is to help you all see the value of a flexible PBM option like Abarca and opening the door to new partnerships to innovative and best-in-class partners like Free Market Health. We are happy to make this interactive, so feel free to jump in, ask questions, share ideas. I think we all learn best when we interact with each other. Sound good? So let's start with some of our shared challenges. If we're being honest, over the last couple of years, and even the presentation before this was a great lead-in, the themes tend to be pretty consistent, and from one of these forums to the next, they transcend markets, they transcend plan types, and they're only getting louder. We all know that drug costs are rising, especially specialty drugs that are eating into our budgets faster than revenues can keep up. And as a result, it's opened the door to uncover a lot of the deeper problems within the legacy PBM model that is limiting plans from trying to find solutions of their own. There are major transparency gaps. Oftentimes, we're burdened with limited accessibility to data or line of sight to things like drug pricing, rebates, the true economics of the benefit to help solve financial problems. We're stuck in rigid models with PBM contracts that are designed around a one-size-fits-all, when we all know that every plan has unique populations and priorities. And we live in a very fast-moving environment where yesterday's claims can't exactly predict tomorrow's spend, especially with the added pressures of regulatory environment, government intervention, the rapid pipeline of new specialty therapies like oncology and gene therapies and rare disease drug costs. So as we try to navigate and find a better way, we need to acknowledge that the problem isn't just about cost. It starts with control, transparency, and the ability to quickly adapt. Show of hands, how many can relate? A lot of you have a lot of those same problems. Now, for years, the industry told us that the solution was vertical integration. One roof, one platform, one experience. And sure, on paper, that sounded great. More negotiating power, bundled cost discounts, integrated data, streamlined member experience. But here's the truth that often gets left out of the story that many plans are experiencing now. Market consolidation has only reduced competition and left plans with fewer choices. Conflicts of interest have emerged. Plans are forced to partner with a PBM who owns their competing health plans. And now they have to compete with them, not only on a carve-out basis, but also on a carve-in basis, and rely on them for their cost of goods at their pharmacies. Transparency hasn't really improved because, if anything, it probably has gotten worse when the couch cushions just got a lot deeper to move money around and the dollars are even harder to trace. And perhaps the most concerning part is the loss of optionality. Plans are locked into one system where they must use that PBM for all cost of goods, all programs and clinical services, their networks, their pharmacies, regardless of every piece of the puzzle, truly fits all of their needs and is the lowest cost and effective options. And while the vertically integrated entities doubled down on control, the world outside was exploding with incredible innovation. Industry champions heard our problems and started to take action. New startups, tech-enabled point solutions, new cost models and transparent discount solutions, targeted clinical solutions for all these top spend drivers like oncology, diabetes, weight loss, gene therapy, and more. Same-day home delivery with the click of a button, AI integration to streamline PAs, specialty models that improve access and lower cost, all promising smarter, more efficient, more transparent, cheaper, and more personalized approaches to healthcare. The tragedy being, the legacy model has most plans locked out from accessing them. So how do we create exceptional healthcare that is affordable, accessible, personalized, and seamless? If there's one thing my career has taught me, having worked with thousands of plan sponsors over the years, it's that the one-size-fits-all solution doesn't work. Every plan is different. Every population has unique needs. And so the answer lies in moving forward to a next-generational pharmacy programs that are modular and allow for flexibility. And we're back. So plans should consider a partner who gives you back your autonomy, the freedom of choice for best-in-class partners to maximize value and tackle unique needs, a modern PBM platform that unifies all of the core functions and enables accessibility to real-time data to all of the pieces, all the data, to improve transparency and efficiency. One that enables seamless integration to effortlessly connect with healthcare point solutions and strategic cost management partners, and provide a superior healthcare experience by embracing innovation, things like the power of AI, new technology, for clearer, easier experience for members and providers. Think of it as disaggregation with purpose. Instead of being bound to one closed system, modular PBMs allow plans to plug and play with best-in-class innovators. Want the most advanced specialty solution? Choose it. Prefer a unique digital engagement tool? Integrate it. Find a rebate aggregator who's more transparent and has better contracts. Capitalize on it. Need to pivot as new therapies or policies hit the market? You can. And we've seen bold leaders step into this space, Blue Shield California being one of the most public ones. But they won't be the last. Because the truth is, this isn't just a trend, it's the future of how pharmacy benefits should be delivered. At Abarca, our purpose is simple yet profound. We believe in finding a better way to work together, connect with each other, and make healthcare seamless and personalized for everyone. And at the root of our mission is one of our core values, humble competence, which means we deliver what's needed to execute, grounded in humility and driven by purpose. And we recognize that no single entity can be the best at everything. The old saying, the jack of all trades is rarely a master of many. So instead of trying to own every piece of the puzzle, we built Abarca with the humility to say, let's focus on what we do best and partner with those who can do the rest better. So the modular approach, it isn't new to us. From day one, we designed a platform, Darwin, to be modular, interoperable, and flexible. Every strategic decision that we make comes back to the question, do we build it, or do we partner with a best-in-class innovator who can deliver it faster, better, and more cost-effectively to best serve our members? That's why we've integrated with more than 25 innovators across the healthcare spectrum, and for years have been deploying a flexible modular strategy for our existing and prospective clients. It's why we were selected to power solutions like Blue Shield of California. And it's why our clients can pivot quickly as markets evolve without being shackled to outdated infrastructure. And don't get me wrong, we have a lot of great homegrown capabilities and over 80 modules in Darwin, but we want to give our clients that optionality to explore the market and use other solutions as well. Now, I know some of you may be thinking, Scott, that sounds great, but I'm not quite as big as that, or I don't have the resources, and managing multiple vendors may sound like a nightmare. Here's the thing, you don't have to. If you want, you can delegate it. We understand it's time-consuming to manage several partners and can be more costly from an administrative perspective. But through the years of building the foundation of this model, we already have the partnerships off the shelf to deploy and are willing and able to connect with new ones to best fit your needs. Abarca can serve as the hub. We can partner with you to understand the strengths and opportunities, to choose the best partners, manage the relationships, the integrations, the administrative complexity. And because we're already connected to those 25 strategic partners, you already have options. Your barrier to entry is lower. The administrative burden is lighter. And your solution can be personalized, not just at the plan level, but at the subgroup level. In other words, you get the flexibility without the chaos. So I began this conversation. Many of you agreed that there are consistent burdens in the market due to a lack of transparency, lack of fair competition accessibility, and a pipeline of specialty drugs costs that are killing our budgets. And throughout, I've alluded to the wave of incredible innovators stepping up to address these challenges head on that you are probably missing out on. So to showcase the value of flexibility, let's dig a little bit deeper into one of our strategic partners, Free Market Health, who is doing just that. So in the typical PBM model, when it comes to specialty, you usually have one of three options. The most common being an exclusive offering, where it's one size fits all, and you're typically funneled into a single specialty preferred pharmacy, most of the time owned by the PBM. And so maybe you get a little bit more aggressive of a guarantee because you can expect all the volume to go there. But it does limit the flexibility to adapt to regional needs and still requires a specialty pharmacy rep for things like LDDs or pharmacies that are not, in that same region. You also have the managed or limited, which is a little bit better. Usually 2 to 4 specialty pharmacy options. The PBM specialty owned pharmacy is usually in there with a few others. Gives that member a little bit more optionality, but you start to lose out on some of those savings. Now it gets a little bit harder to predict where the drug spend is going to go, so pharmacies usually give you a lower rate. And then you have the broadest, which is the open concept, any willing provider. And in that concept, members are able to choose any specialty pharmacy, but now your discounts tend to get much lower because it's really hard to predict where that spend is going to go. And you start to lose out on some of that ability to manage the clinical initiatives. Well, Free Market Health opens the door to a brand new specialty network option solution. One that gives you a lot of the upside of all of these options. So please join me in welcoming Mike to walk you through how they have brought a new solution to the market for drug specialty management with technology, improved accessibility, and their marketplace model with a relentless focus on value. Please join me in welcoming Mike.
Wow, I am so excited to talk about this. I am brand new to FMH. I just joined in mid-July. And am I mic'd up or do I need to stand? Can you hear me okay if I don't stand behind the podium? Okay. So really excited to talk about this model congratulations, or thank you, Abarca, for recognizing the value that we're bringing to the market, because we do believe that pharmacy benefits need to stand here? Okay. Pharmacy benefits do need to adapt with the changing regulatory environment, with the changing expectations of plan sponsors, and overall the economics are just shifting very quickly in the marketplace. So when I joined FMH not that long ago, I ran into two types of people in my network. 80% of them were, what is free market health? And 20% was, why did you go to free market health? So today I'm going to go through what is free market health. But I think for you to best understand what FMH is, if you understand a little bit about my career leading up to this moment, it probably will all start to connect for you. So I've been in specialty really from the dawn of specialty. In 1996, worked at Statlanders, right? First specialty pharmacy in the country. Then from Statlanders, I graduated pharmacy school, and I worked in retail and hospital environments for about 6 years. I ended up building a hospital pharmacy within one of my health system pharmacies, and through that venture, joined UPMC Health Plan, right at a point, this is circa 2005, right when Part D was starting to happen, right when specialty started to become relevant. I mean, I think Enbrel was like $800, and it was blowing people's minds right back then, right? When specialty were, how could we possibly have an $800 drug? So 6 years at UPMC, got really deep into everything health plan around specialty pharmacy. From there, I went to Walgreens Specialty Pharmacy, and I helped them build their national payer strategy to sell into large managed care organizations a specialty dispensing solution that was different than the vertically integrated carve-in solution that the big PBMs were all selling. Back in that time, that was a really effective message, and we had a lot of success. If you remember, if you were in the industry back then, a lot of narratives of fox guarding the hen house. All these drugs are getting really expensive. You don't want your PBM and your specialty pharmacy to be connected. And so the message worked really well. We did some really innovative programs with Walgreens Specialty. Then the market started to shift because the large organizations, and I'm not anti-PBM by any stretch, right? They have a very important role in the marketplace, but they figured out how to start to align contract incentives in a way that made it very challenging for an organization to start to kind of continue with the carve-out message. It still worked for some, but it became increasingly difficult. And so things started to shift back into the vertically integrated model back in 2011-ish, really 2015-ish timeframe. And that's when I joined Maxer, National Specialty Pharmacy. I ran their specialty pharmacy, rare and orphan, cystic fibrosis-focused pharmacy, and I was chief pharmacy officer of the PBM. And so now I'm in the mid-market, PBM and specialty pharmacy space. And I grew a deep appreciation for not just large specialty pharmacy care models like Walgreens delivered, but also rare and orphan models that Maxer delivered. And I got exposure to the employer group side very closely around what they expect from kind of a different PBM model through a mid-tier. So 6 years there, great 6 years. Then I joined Optum as their chief pharmacy officer, OptumRx, as CPO at OptumRx for 3 years. So now I went to one of the big three and brought into the big three these perspectives of, well, I've seen small specialty pharmacy, I've seen large specialty pharmacy, I've seen health plan, I've seen mid-tier PBM, and big PBMs are getting a really bad rap out there. Right? And maybe I can go into some of these perspectives and start changing some things. And it was a great experience. And I can tell you there are a tremendous amount of great people working, not just at Optum, but probably all the big three PBMs. But the business model itself is extremely difficult to change quickly. Meanwhile, the market is demanding changes to happen quickly. And so I had a personal decision to leave Optum for some personal reasons, which I won't get into with, we all, many of us experience with aging parents. I took a year off and I did some independent consulting, and I started to talk with FMH. And everything FMH was trying to solve was the mindset that I had throughout my career. And there's one consistent thing throughout that career is I've always been an advocate for specialty pharmacy, like very deep from the very first day at Statlanders. And what FMH does is create a modular model that plugs into an ability for plan sponsors to exercise a new approach to specialty pharmacy within their benefits. What do? We enable specialty pharmacies to compete or to participate differently in areas where they feel they are best positioned to succeed as a specialty pharmacy. So that's what I'm going to get into today. So now, clicker. Not that button. Other button. One of these buttons.
Big middle one, yeah.
Middle button. Okay. So so what is FMH? So now you know why I'm at FMH, because I believe in the model that specialty pharmacies of all shapes and sizes have a place in this marketplace. They need help with accessing the lives to bring to their front door and at terms that they can accept. Because what's happened over time with vertical integration is the independent specialty pharmacies have primarily been locked out, right, because of the vertical integration. And health plans have less options around, we mentioned this earlier when Scott was talking around regional solutions that are now increasingly important, right, to health plans to work with healthcare as local type of approaches to the marketplace. So what do? First is we go out to specialty pharmacies, again, all shapes and sizes, and say, where do you feel you are best positioned as a business to bring value as a specialty pharmacy? They choose the drugs they want to participate with. It might be a therapeutic category, like oncology. We want the best oncology pharmacy in the network. Right? It might be cystic fibrosis. We want the best CF pharmacy in the network. You don't need to do everything. We actually encourage the pharmacy participants to specialize in what they do best. Then we take all those pharmacies, they tell us what price they're willing to accept. We take them all to the payers. And then we say, you have the ability to design a specialty solution however it works best in your market. Here are the pharmacies that are willing to participate. Here's the prices they're willing to participate at. So it's not super complicated. What FMH is doing in the middle is just playing matchmaker between willing pharmacies who are really hungry for business but challenged on how to go get it, and we go to payers who are really challenged for novel, innovative solutions, but they can't work within easily vertically integrated organizations to deliver a customized solution for the regional marketplace. So most importantly, there's a patient within all of this, right? And from that perspective, FMH has an operating model that not just brings the pharmacies to the payers, but we have an operating model that's very important. We get embedded in the health plan workflow and embedded in the pharmacy workflow. So we're in a very unique, we're a technology company, right? It's our platform, our plan sponsors program. How they administer their program, we work with them on it, and we can guide them to what works best, but ultimately it's their decisions, what pharmacies they want to work with, how they want to work with them, what prescriptions do you want to go to which pharmacy, even at the doctor prescriber level, right? They might want some scripts to go to one place and other scripts to go to another place because they think that's what's best in their marketplace. We work with them all that. The patient experience, that's the next question I get. Well, doesn't that disrupt the patient? No. It actually augments it because now we're uniquely positioned. We see every prescription that gets started, right? We have eyes on it. We know it went to a pharmacy that's out of network. We can help get that script to the right pharmacy quicker so the patient doesn't get lost in the shuffle, which happens all the time. We have visibility to the pharmacy, where is the script at in their workflow. We have visibility to the health plan, bidirectional communication to both. So we're constantly monitoring what's happening with the specialty journey for every new patient. So the message is resonating in the payer community. So while we enable pharmacies, our primary customer are payers who choose us. This slide indicates the bar chart represents the specialty volume at an AWP level that's going through the FMH platform today, or over the last few years, I should say. So 2025 will distribute equivalent of $5 billion of specialty utilization into this diverse network of pharmacy partners. Next year, we have some significant growth in front of us, which is super exciting and a little bit scary at the same time because we're going so fast. So there's a massive operational build-out that we're currently doing. There's the technology stack is ready to go. We're going to triple the size of the business next year by significant payer growth and some of the largest, most sophisticated plans in the country who are choosing a different model for specialty. So really exciting time for me to join because, again, I feel this is a very unique solution that keeps the patient experience at the center through the operating model, but allows specialty pharmacies, we're putting oxygen back in the room for them, right? We're giving them an ability to be in a marketplace, get access to payer lives, where there's really been nobody's been advocating for the mid-tier pharmacies for a while, and now we have health system specialty pharmacies that some health plans embrace them with open arms, other health plans are like, whoa, hold on, you're gonna take my rebates, right? Our platform can balance all of that, right, based upon the plan sponsor's individual strategy, which is why you're seeing this growth on the chart here. So simply, it's bringing together highly capable specialty pharmacies. It's bringing our platform to payers who now can use the platform to distribute specialty into their communities or nationally, however they want to, in new ways with great lines of sight into what's happening. And of course, service-driven and with that operating model that I mentioned with a team of very passionate, clinically minded pharmacists and technicians that work at FMH that work with our health plan and pharmacy partners. So what does the network look like? We have roughly 100 participants in the specialty pharmacy ecosystem in the FMH platform. I would say if you looked at our data, there's 40 meaningful participants, who are highly engaged. And it includes hospital pharmacies, it includes mid-tier pharmacies, regional specialty pharmacies, it includes large pharmacies as well. We have relationships with all the large pharmacies. They participate at different levels of engagement. Again, they're choosing where to participate. You can probably imagine if you're a big 3 PBM, you're looking at saying, do I work with this or do I work against it? And we're seeing different perspectives from different organizations, which is okay. But it creates we want big pharmacies in the network because we want all the pharmacies in the network. There's not a good or bad pharmacy. It's a matter of tailoring a patient experience and the rates and terms, across all formats, and then bring it to the payer for them to pick. So, we're not for or against any one particular type of pharmacy. We want to get the patient to the right best fit pharmacy through our program. And so we have that collection of pharmacies. They've all agreed to rates at the NDC level for products. They also get to participate in what we call a live referral mechanism, which is where the company started. And so what is live referral? Well, FMH creates these routing rules that I mentioned based upon pricing that our pharmacy partners have agreed to, and there's routing rules that the payer sets up. But what happens if the payer doesn't have a routing rule established for a particular drug? Well, then it hits a live referral queue where any pharmacy participating in FMH that the payer wants in their plan to participate, they see there's essentially a portal that pharmacies sign into, and they can see every new patient that comes through our system, and they can tell us the rate at which they will onboard that patient. So most of the pharmacies will, at the NDC level, set up programmatically, I'm willing to fill Skyrizi patients at AWP minus 20%. I'm making up the number, right? And then as these referrals come through live referral, it will get assigned to the pharmacy. If it hasn't been routed intentionally somewhere first, then the pharmacy that most aggressively is participating in the live referral platform will get awarded the referral. The whole time, no matter which route the process takes, there's a service center that's monitoring the referral. And what we found, which is really exciting, is because we have eyes on everything, that patients don't fall through the cracks anymore. Because you might be asking yourself, how do you know when a new patient exists? We integrate with a lot of technology across other stakeholders in the industry. So when a payer approves a prior auth for a patient, for one of their members, we have an API into them that alerts us instantaneously that Skyrizi's been approved for my guidance chauffeur. We then instantaneously, in milliseconds, check to see if there's routing rules established for that NDC, for that member, for that payer, based upon the prescriber NPI, could even be ICD-10 codes. The attributes you can use to assign are pretty infinite. And then we're aware of it, and the process kicks off at FMH. So it's a really elegant system because we can become aware as soon as the prior auth is approved. Now, in the wild, so to speak, chances are that prescription ended up at a pharmacy that's, and this is any model, not just FMH. In a vertically integrated model, physicians send prescriptions everywhere. Right? They have no idea whether a pharmacy is in network or out of network for the patient that they just saw, because they're seeing patients of hundreds of different payers, like on any given day. So patients get lost in the wild because the script got sent to, let's say, a Credo, but it's a CVS Caremark member, and so now it has to be filled at Caremark, script sitting at a Credo. Patient probably left the doctor's office not even remembering the drug they were prescribed, let alone like where the prescription is. And those patients fall through the cracks and never go on therapy. What we do is, since we're aware of it right when it's approved, we increase the onboarding, we decrease abandonment rate by 40%. Because if we see a prior auth get approved and we don't see a pharmacy filling it, then we're calling the pharmacy and saying, we sent you this 2 days ago, why haven't you filled it yet? Which, a really fascinating story, like anecdote, is before I joined FMH, they retained me, I was an independent consultant for a while, they retained me to do an independent survey of their specialty pharmacy participants. And I thought, well, this is really cool, like I'll get a little bit of direct insight into how do the pharmacies feel about FMH. And it was, it was overall very, very positive, with one main complaint, and I love this complaint. It was, for what can FMH do better, the number one thing was, you don't have to call me all the time about where the prescription is. I know it's going to get filled, but to me that reflects that this is very real. Like the service model and no patient left behind is very real. And we're integrating technology so that we don't have to call the pharmacies or to check on status. We're API integrating into them, so we have direct connectivity into their dispensing systems. This is all an evolution, right, that leads to getting specialty pharmacy to be delivered as seamlessly for everybody, right, for the payer, for the pharmacy, for especially the patient and the provider. Okay, so you can tell I'm not a super slide-driven person. Marketing creates all these great slides, and then I go and front run all the information before I get to the slides. So some of this will be a little bit redundant, but probably because it is a lot to take in the first time you hear about what we do. Quite simply, where we're not involved in the physician and patient determining they should start on a specialty therapy. But once that decision is made, there's multiple ways we get activated. I mentioned how we connect to the prior auth system through an API, but we also last year launched a non-dispensing pharmacy with FMH, and physicians can prescribe directly to our pharmacy. So now we're upstream and have immediate awareness where where a pharmacy, when a patient has been prescribed a special medication. Now we can help get the prior auth, right, rather than have the pharmacy go out and do it. We also get claims data from our clients, and so we can see rejected claims. And if there's a rejected claim for a prior auth need, we can immediately get activated and take action on it. So now we have these different intake mechanisms coming into FMH. We use our technology platform to get the prior auth as quickly as we can for the patient. Then we assign the patient to the pharmacy as quickly as we can based upon the payer routing rules. And then we have pharmacies who, really important point, we are not intending to be another person the patient has to talk to. We feel patients get overburdened already with being contacted from maybe the hub, maybe the payer, maybe the specialty pharmacy, maybe the doctor's office. Like, they don't need another phone call from somebody they don't know. What we do is empower those endpoints with better information so that when they talk to the patient, they're giving the most accurate and effective information they can. So we relay to our pharmacy partners. They're the ones that are going to connect to the patient and say, hey, welcome to XYZ pharmacy. We're going to be taking care of your SCAR-Z prescription. And so that's how it all works. Same thing for the payer side. The payer would be the one that owns the patient-member relationship, not us. But it's complicated, but it's not. It's simply bringing the pharmacies and payers together and enabling them to get a patient to a more modernized specialty solution. Okay, I mentioned the connectivity, and the heart of the company, we're a technology company. A lot of complex things to work through here. We have the plan that needs to set the routing rules and how they want to administer the specialty benefit. We have to connect to the vendor with APIs. We connect to the PBM. So Really important part, as we're setting this pricing with the pharmacies, the PBM needs to know how to adjudicate the claims, right? So we have APIs into the PBMs that in real time tell the PBM what pharmacy can fill the prescription at the member NDC level. So this is member level, like claim level API information going to the PBM to say, for this member, for this NDC, can only be filled at this pharmacy at this rate. And it's all automated, like through APIs, which is, I think, a super cool kind of use case of how PBMs are modernizing. And this is partnering with the large PBMs. So like they're responding in a very positive way to how this model is kind of changing how care is delivered. Then ultimately there's specialty pharmacy, where again, we have APIs into them. One of our large pharmacy partners, really sophisticated, and they of course have an interest in getting the most efficient process on their side. So rather than them needing to work in our portal to understand what new prescriptions are coming their way, we build APIs with them that feeds directly into their dispensing system, right? Super seamless. It just looks like any other prescription coming in, and a really exciting thing for me to see is a 30-year advocate of specialty pharmacy. Really quick, I know this is going to be small, but just a little bit of UIs. The FMH team here and myself happy to sit down with anybody and walk through in detail more how the platform works. But simple screenshot of what one of the screens in this happens to be the FMH for pharmacies app, just what a pharmacy would see. And it says, basically we call it the pizza tracker, right? Very sequential, very logical, tracking of where any prescription is for any given member at any point in time. As it moves through the stage gates, we have eyes on everything that's happening. This is literally the screen that is shared in the support center. So when we're getting a phone call from the pharmacy or a phone call from the payer, everybody's seeing the same thing, and we're chatting with them through the platform. Any pharmacist in the room, should get really excited about this. This technology is purpose-built to effectuate what we call value cases. So yes, pharmacies need to be competitive on price, but man, I hate the fact that pharmacists, for as long as I've been a pharmacist, almost 3 decades, that your business lives or dies on what you get paid for a drug, right? We all have wanted to get paid for clinical services for decades. So the platform is purpose-built to issue direct payments to pharmacies for specific clinical interventions that the payer wants to happen, right? So we can, just like we deliver a prescription to a pharmacy, joining that prescription is what we call a value case when the payer wants it to happen, to say, hey, we'll pay you an extra $150 to do an SDOH survey or to do a clinical assessment. Really exciting kind of segregation of the pharmacy drug reimbursement and the value of a clinical intervention that the pharmacy can effectuate, document our platform, and we pay them without them having to do anything additional. Last thing I'll end on, I mentioned the non-dispensing pharmacy. Another really exciting piece of the technology platform. Simplest path now to make this all come together is send us the prescription, right? Let us get upstream from the PA. We'll do the PA. We acquired a company called Beeline about 3-4 months ago, built by former Hub founders who know pharma really, really well. So we acquired them to improve our ability to do prior auths on behalf of our plan sponsors and our patients for our pharmacies. Right? So you can tell we're very focused on just making this all more efficient for everybody. So doc can send us the script. We can start the PA in our system. We have connectivity into the health information exchanges. We have digitized the PA forms. We can populate the PA forms, send the NCPDB transaction to the payer if it's a pharmacy claim, get the PA approved, and then instantaneously route it to the pharmacy without the doctor even knowing that a prior auth is required, right? And this is where things are going looking forward a year or two. As this scales, this is what we'll be talking about next year. Okay, we delivered that almost right on time. we have a clock here. It's like 1 minute, 34 seconds left. So I think we have time for a few questions. Scott?
Hi. By the way, the product about reimbursing pharmacists for clinical services, that's becoming common legislation. So a tool to do that is, because they don't know how to bill, don't have the access to bill for it. No one knows how to pay them. So I appreciate that. Back to the modular approach, and I think we are seeing a lot of clients wanting to kind of split the services. The one question and thing that I've been struggling with, and maybe this is just nerd lawyer, right, is accountability. So if one entity messes something up, let's say the one that's doing the reimbursement doesn't have the right minimum payment, the state comes in and says you got to pay a penalty ranging from $5,000 to $10,000 or whatever. If you've got multiple folks that are part of the PBM environment, are you seeing a situation where the state agencies are saying, oh, I'm going to penalize all 6 of you each for one violation? How does that get distributed, like when that works?
No, it would typically still be at the core of the one-time penalty. However, within the managing, usually depending on who wants the ownership. So if the health plan wants the ownership of the modular to say, I want to be my own PBM and I'm leveraging all these, there's kind of 2 models. Or you use someone like Abarca who is modular and we're going to manage it. At that point, would do the navigation of who is the actual root cause and responsible and how does that get divvied up in between? Is there mutual? And then coming to mutual agreements within how it's contracted, essentially.
Thanks, that's helpful.
I think we are right at time, but if anybody wants to grab either Scott or I after I think we're going right into the coffee break. So thank you for attending.
Awesome, thank you guys.